Hello, and welcome to Conversations in Lung Cancer Research, a TOGA podcast where we discuss the latest in lung cancer research and practice in Australia and New Zealand. My name is Rebecca Tay. I am a medical oncologist at the Royal Hobart Hospital in Tasmania. Before we begin this podcast, the Thoracic Oncology Group of Australasia acknowledges the traditional custodians of the land on which we live and work. We pay our respect to their elders, past, present and emerging, and extend that respect to all Indigenous people. Characterised by rapid tumour growth, early metastatic disease and poor prognosis, small cell lung cancer impacts the 10 to 15% of Australians who are diagnosed with lung cancer annually. And despite initial sensitivity to platinum chemotherapy, there are high rates of relapse and disease resistance observed, which make this disease such a challenge to treat. In today's podcast, we hope to provide practical insights on the management of extensive stage small cell lung cancer, as well as discuss some of the latest updates as we enter an era of combinations and novel agents that are reshaping the small cell treatment landscape. I'd like to thank Roche for sponsoring today's podcast. I'm excited to be joined today by two fellow friends and oncologists who both specialise in the treatment of thoracic cancers. Today we have Associate Professor Surein Arulananda, who is the Deputy Director of Medical Oncology and Thoracic Oncology Trials Lead at Monash Health. He also holds an Adjunct Associate Professor position with Monash University. And I'd also like to welcome Dr. Dasantha Jayamanne, who is a radiation oncologist at the Royal North Shore Hospital and Genesis Care in Sydney. Welcome both Surein and DJ to TOGA's Conversations in Lung Cancer Research. Thank you, DJ and Surein, for joining us. Surein, could you walk us through the current first-line standard of care for extensive stage small cell lung cancer in Australia and why this disease remains such a formidable challenge to treat?
Thanks for having me here today back to talk about small cell lung cancer, which traditionally has been a disease that one would argue has been very difficult to treat. They would hardly get a podcast, to be honest. But now there have actually been a lot of not just podcasts, but various workshops talking about the disease because of the avalanche of treatments that are starting to come into this space. But really, if you think back to this, for decades, really up to about 2018, the only active treatment we had in the first-line setting for extensive-stage small cell lung cancer was platinum etoposide chemotherapy. And then we saw the first study where the addition of atezolizumab with platinum etoposide chemotherapy demonstrated an overall survival advantage in the IMpower 133 trial. But a year later, we saw data from the Caspian study, which was the addition of durvalumab to carboplatin or platinum etoposide-based chemotherapy, also demonstrating an overall survival advantage. And although that overall the actual benefit was relatively modest, what I mean by that is that when we go back and look at the studies and look at the long-term survival, the reality is that an additional 10% of patients are certainly benefiting. But given the fact that there was a survival advantage with hazard ratios in the order of about 0.7 respectively, this treatment has been incorporated into standard of care. But naturally, we are looking for more treatments that will be able to give our patients longer-term benefit. And that is what's really exciting about this in this space. If we could, I guess, deep dive a little bit into both IMpower 133 and Caspian, essentially both trials are very similar. The trials included patients with treatment-naive, extensive-stage small cell lung cancer, who are typically eligible for a first-line clinical trial with pretty standard inclusion-exclusion criteria, and randomized the patients to the platinum etoposide-based chemotherapy with or without the checkpoint inhibitor. Probably the only real difference between the studies is that in IMpower 133, patients who are enrolled needed to have treated brain metastases, whereas in Caspian, patients are untreated asymptomatic brain metastases for allowed on. Nevertheless, both studies showed, as I mentioned earlier, fairly similar outcomes with hazard ratios in the order of about 0.7 with IMpower 133 and a hazard ratio of 0.71 in Caspian, really meaning that about up to 30% of patients benefit from the intervention. What I was trying to allude to earlier, however, is when you look at the landmark analysis, such as in IMpower 133, at about the 12-month mark, 52% of patients were alive compared to 38% with the control arm. We saw some 5-year survival update in IMPOWER 133, and that was about 12%, which, although that certainly sounds very, very modest, really in extensive stage small cell lung cancer, that data is actually quite revolutionary because traditional data would suggest that the 5-year survival was actually, if anything, in the order of single digits, really. And certainly, the other additional factor to point out is that there are no biomarkers that are reliable in order to predict patients that can benefit from this intervention. In fact, PD-L1, which is, of course, the biomarker of choice in non-small cell lung cancer, doesn't seem to be a predictive biomarker in this context. Recently, we did some work between two institutions, which we published several years ago, where we looked at a real-world series of Australian patients with extensive stage small cell lung cancer who were treated with upfront chemoimmunotherapy. And we were trying to understand if there were any predictive clinical factors that could predict the improved survival. And we found that if patients were able to complete all their 4 cycles of chemotherapy and had lower LDH, for instance, which we know LDH is a biomarker for disease volume to some degree, that patients do better. So that is fairly intuitive, but ultimately we don't have a reliable biomarker. And this is very much entrenched as our current first-line standard of care in Australia.
Thanks so much, Surein, for that extensive overview. And I also just want to acknowledge that we are fortunate to have access to PD-L1 agents in extensive stage first line, whereas just next door in New Zealand, I believe it is not reimbursed therapy. I guess along a similar track, DJ, I wanted to ask you from a radiation oncology perspective, does radiotherapy enter the standard treatment pathway for extensive stage small cell lung cancer?
Thanks, Rebecca, and thanks so much for having me. And lovely to get a background from Surein about all the things that have changed and what's standard of care at the moment in the medical oncology sphere. And I guess to echo Surein's thoughts as well, just looking at the last 2 to 3 decades, sadly, we haven't had a lot to be excited about. And as he said so eloquently, it's hard to imagine many speaking points for small cell lung cancer, especially in the extensive stage, for both of us in a lot of ways. But touching upon what's standard of care at the moment, I guess the crux of our role is still in a symptom management perspective. So patients who have symptomatic progression, pain, obstruction, CNS symptoms, or other malignant symptoms from their tumor lump locally, we certainly consider them for radiotherapy. And that's often in a short fractionation of treatment, and that's been well established for decades. Interestingly, the thoughts of chest radiotherapy or brain radiotherapy have been well discussed, established, and there's a bit of research that's happened over decades to try to enlighten us on when we might need to step in asymptomatic patients. So I suppose historically the most obvious of those roles is in the chest, where we have consolidated the good work of our great chemotherapy doctors by giving some chest radiotherapy. And that was, if you like, shown in a trial called the CREST trial that many of us are aware of, where consolidation after chemotherapy in patients who had not progressed showed a PFS advantage, but no real survival advantage at 1 year, which was the aim of this study. We sometimes try to squeeze out that the 2-year survival was slightly better. And so maybe for patients who respond to systemic treatment or have longevity, there might be a role for radiotherapy in improving their outcomes. Although with the new immunotherapy agents, it's really difficult to know where we stand from a radiation doctor point of view for the chest. Of course, there's the TROG study, the chest RT study that's looking at feasibility, and another called Raptor from the States looking at a phase 2/3 randomized study as to whether or not there's actually an efficacy advantage in adding radiotherapy in the immunotherapy era. Practically or pragmatically, what I tend to do in the clinic is really assess how the patient's thoracic burden of disease in comparison to their extrathoracic disease has featured in their diagnosis and how bulky this is. And if they've had a decent response to systemic treatment, I think it's worth considering until these trials read out. I suppose the other interesting point is brain radiotherapy, and we'll probably delve into this later in the podcast, but just as a snapshot, I guess the most pertinent thing to say at this point is given that there's a bit of data with the randomized Japanese study looking at whether or not PCI, which was the previous standard of care, versus observation in MRI has any advantage in survival. What we learned from that study at a high level is that perhaps if you've got good access to MRI and can do MRI scans regularly at 3 monthly intervals, there's probably no detriment in survival in adding MRI surveillance. And certainly there are toxicities of PCI. So that's what my practice is often about in the country or in the city. I'd prefer to use a PCI avoidance strategy with MRI.
Yeah, thanks, DJ. It's great to hear your perspective. And it really shows that cooperative trial groups are really well placed to answer really important research questions. So, whilst checkpoint inhibitors have really changed first line standard of care, unfortunately, the majority of patients will progress. And in Australia, really outside of a clinical trial, our options, and particularly reimbursed options, have been limited to chemotherapy. So agents such as topotecan. In my practice, I may utilise rechallenge platinum etoposide chemotherapy in platinum-sensitive disease. However, what we observe in the clinic is these chemotherapy agents have really limited efficacy, certainly much lower responses and duration of disease control. And there's a significant therapeutic gap in this space. I guess excitingly, in recent months, we've really seen a shift in the treatment paradigm for extensive stage small cell lung cancer, with positive readouts of 2 major phase 3 studies in the maintenance and the second line setting, respectively. So I might just speak on Inforte, which was presented at ASCO this year. So Inforte was a phase 3 clinical study in the maintenance space. And this trial enrolled patients with extensive stage small cell lung cancer who did not progress after induction platinum etoposide plus atezolizumab. And patients were randomised to one of 2 arms, the first arm being lurbinectedin at 3.2 milligrams per metre square, which is the standard dose, plus GCSF prophylaxis, plus maintenance atezolizumab, or a control arm of atezolizumab alone. And both arms were continued until disease progression. So this study demonstrated a small but statistically significant survival benefit. The median OS was 13.2 months compared to 10.6 months, importantly from the time of randomisation. I guess based on these results, lurbinectedin is currently under consideration for reimbursement in Australia, which is an exciting step to have another agent in our tools to treat patients. So I want to ask you, Surein, which type of patients would you be considering maintenance lurbinectedin in if this was available?
Yeah, this was a very interesting trial that was presented at ASCO. As you mentioned, it was particularly interesting because it read out for an improvement in overall survival. So certainly in a disease where there have been very few real advances, even anything with an overall survival advantage really needs to be taken seriously. But when we look at this trial, there was quite a few nuances to discuss. First of all, patients could not be enrolled in the trial if they had brain metastases up front. So we know that a proportion of our patients will have brain metastases up front. So that sort of excludes that population. And what I thought was particularly fascinating is that, as we know, when we recruit patients to first-line clinical trials, they need to be pretty fit to make that clinical trial. And when we talk about patients with extensive stage small cell lung cancer, we're talking about another fraction of patients, if you like, who are fit enough to go into a clinical trial. And this trial recruited patients upfront before they started the chemoimmunotherapy. And despite that, close to 30% of patients never actually got onto maintenance. And that was quite interesting, wasn't it? And certainly a proportion of patients experienced disease progression, but never toxicities. And we know that platinum etoposide chemotherapy for 4 cycles has toxicities such as cytopenias, etc. Right? Now, the study was, of course, incorporating lurbinectedin as a switch maintenance approach. And some of the arguments are that we are bringing an active drug earlier into the treatment paradigm. It is very difficult to tease out if the benefit seen in the study was purely additive, purely synergistic, a bit of both, or once again, was it really that we are minimizing attrition? Attrition is one of the biggest problems in small cell lung cancer. Approximately half the patients who progress on first-line treatment will never make it to second-line treatment. So it makes sense to bring drugs earlier into the space. So if this treatment is approved tomorrow and I have access to it in the clinic, and I think outside of having access to all other clinical trials available, I certainly would consider this. I think if patients are fit enough after having completed 4 cycles of platinum etoposide chemotherapy and their quality of life is fairly reasonable, when they are keen to have the maximal treatment to improve their long-term outcome, then I think those are the patients I would certainly introduce lurbinectedin into in the switch maintenance setting.
Yeah, I agree with you, Surein. Now, I want to talk about the second line and beyond. And the agent that's really been making waves is tarlatamab, which is a first in class DLL3 targeted bispecific T cell engager. And Surein, I know that you've been an investigator on numerous Delphi studies. Can you tell us a bit more about the unique mechanism of action of tarlatamab?
Thanks, Beck. I've been very fortunate to have had the opportunity to actually be a primary investigator on the Delphi 304 trial. So, tarlatamab is a unique drug. It actually is an immunotherapy, but it's very different from checkpoint inhibition. What tarlatamab does is it is essentially an antibody, if you like, which has an Fc gamma region, and anchored to it is that you have a site that binds to the CD3 receptor of cytotoxic T cells and another site that binds to a tumor-associated antigen, in this case, DLL3. So what it does is that it basically brings the T cell through the CD3 receptor into proximity with the tumor cell that harbors the DLL3 receptor, and basically then leads to T cell expansion and release of granzymes and perforins, which leads to cancer cell death. That is the mechanism of action of tarlatamab. Now, in the Delphi 304 trial, we saw for the first time, arguably the first time in history, a treatment that improved overall survival in the post-platinum etoposide treatment setting, and with an impressive hazard ratio of 0.6, compared to second-line chemotherapy, which, by the way, included second-line lurbinectedin because a proportion of patients have had that. What I thought was fairly notable is that in the trial, we also showed that tarlatamab improved survival in patients who were considered platinum resistant, so chemotherapy-free interval under 90 days, and very notably in patients with brain metastases. Something I hadn't mentioned before is an IMforte trial, and this is probably just a coincidental thing rather than something to do with the drug. But in the group of patients who received lurbinectedin and atezolizumab, there appeared to be a higher proportion who had brain relapse as their site of progression. In other words, drugs like lurbinectedin are not particularly effective at managing brain metastases. That's why these patients were excluded in the first place. But tarlatamab has excellent CNS activity, and that is a real area of need for our patients. So I think that as far as we talk about clinical trials, from my perspective, it was a slam dunk, and it's really made huge waves in the small cell lung cancer space. And that's why we have so many podcasts and so many webinars now, Beck.
It is certainly an agent we're really excited about. Within Australia, clinicians have had experience outside of a clinical study as well for a short period of time. But I think we also have to acknowledge with novel agents, there are sometimes toxicities that we need to learn to manage in order to be safe for our patients. And tarlatamab has quite a unique toxicity profile, which we don't see with other immunotherapies. So could you talk a little bit about some of these toxicities and maybe some practical management pearls from your experience in the Delphi studies?
Absolutely, Beck. And this is a whole new world of oncology, is the way I look at it. And certainly when I ran the trial, it was very nerve-wracking when we started seeing these side effects and not knowing the severity and just trying to get a feel of things. The idea of admitting patients with second-line small cell lung cancer was considered heresy in some parts of my hospital, but certainly now it's become pretty standard, really, once we started seeing what this drug can really do. So I suppose what we are alluding to, of course, is CRS and ICANS. But before I go into that, I just want to take a step back to point something out. that when you look at the Delphi 304 trial, in fact, overall, in terms of grade 3 toxicities, we are talking 27% with tarlatamab and 62% with chemotherapy. And in fact, the side effects leading to discontinuation was half in tarlatamab compared to chemotherapy. So despite these side effects, which certainly as oncologists, we need to learn how to manage, and it's not just oncologists, right? It's all the staff as well, because as it's a group effort, we're managing patients across the entire pipeline. The reality is that it is actually objectively safer, really, to use tarlatamab compared to second-line chemotherapy. Now, what was interesting about the trial is that initially there was a mandated admission rate for up to 48 hours with the first 2 weeks of treatment, because we know from the trial and other trials that most of the side effects happen in the first 2 weeks of treatment. But later, towards the end of the trial, patients were monitored for up to 6 to 8 hours. In other words, they weren't admitted overnight. And in that group of patients, in fact, the rate of high-grade CRS and ICANS really didn't exist. So there's a sort of a nice proof of concept that if you select the right patients, you can actually manage them as an outpatient. Nevertheless, if we talk about the side effects, so CRS is cytokine release syndrome, and essentially it is documented by fevers and or hypotension or hypoxia. And the management is usually supportive-based medication. And certainly in what we consider high-grade CRS, what I mean by that is when there is hypotension and or hypoxia, the treatment of choice is dexamethasone. And almost always it can be managed that way. In fact, on the trial, the use of interleukin-6 inhibition with tocilizumab was actually very low. But certainly in the unlikely situation someone does develop high-grade CRS, and we've heard about cases through real-world series and from other investigators in the context of real-world use of tarlatamab globally, then tocilizumab is a very effective antidote, if you like. ICANS is an interesting one, right? It's essentially a form of neurotoxicity, and there are these forms now. In fact, in Australia, AVIQ has these forms, and there are a few domains there, including orientation, being able to name things, and that's how you can objectively measure for ICANS. And we also know that drugs like tocilizumab have limited efficacy in the brain. So all the guidelines would suggest that using high-dose dexamethasone would be the way to go. And certainly in the trial, we saw that there were essentially no grade 3 ICANS seen. Most of the ICANS were grade 1 or grade 2 and managed with steroids. So these are different side effects. They're not side effects we have become accustomed to as oncologists. Our hematology colleagues have certainly experienced this. So in some ways, we are now learning from them. And I guess it is important that we upskill our working force. And when I talk about upskill our working force, it's easy for me to say because I'm sitting in a metropolitan hospital, but I recognize that we need to get this drug access to everyone in Australia. And although I always have this joke with you, Beck, because I still consider Hobart as a large metropolitan hospital.
And I tell you, we're regional.
You tell me you're regional. And I guess DJ is definitely in the metropolitan side of things. The point is that we need to be able to get this drug to patients in the regions and to upskill the workforce there so that they're comfortable using this drug so that all patients can get access.
Absolutely. And I think, as you say, it's about sharing knowledge and our experience, and also educating not just our oncology team, but the wider workforce as well. Because just looking at the time of onset of some of these toxicities, it may just fall after hours. And we want to give confidence to some of our after hours cover in supporting it and helping care for our patients. I guess it is a really exciting time in small cell, and there was a lot of discussion when we had checkpoint inhibitors about potential synergy with radiation therapy. So DJ, from a radiation standpoint, do you have any ideas in terms of how these new immune engaging therapies may affect the role of radiotherapy or how radiation may work?
Yeah, thanks, Rebecca. It's really interesting. I was just reflecting on some of what you and Surein were saying there. I work in a central metropolitan unit in northern Sydney, but I also work about 400 kilometres west and just hopped off a flight today from Dubbo. So you're absolutely right, Rebecca. We've got excellent subspecialty medical oncology care out there, but it's about engaging the wider workforce in understanding some of these new drugs and toxicities which become critical and time critical, as you say, in terms of seeking assistance for some of our patients who are geographically, socially, and medically sometimes isolated. So, very interesting. I won't pretend to understand the mechanics or even the pronunciations of some of these drugs. As radiation oncologists, we work in very simple spheres, but I think it's a very exciting time for doctors that deliver local treatment. We've refined some of our techniques in terms of toxicity, in terms of stereotactic treatments, but certainly I think the partnership here is critical, as you say, Rebecca. And there's synergy, of course, with some of these drugs, but there's also spatial toxicities that are quite separate. And when we're defining and deciding treatments for patients, such as additive treatments like radiotherapy, we have to always consider what harm could we do potentially from the treatment we give, but also in synergy with what our medical oncologists are giving. The way I see this, I guess, evolving, which is really exciting for small cell, is that in sites of oligoprogression, perhaps that's when we could probably try to help salvage an area that might not be listening to drug, like we do in the non-small cell and other cancers. The other scenarios, of course, in the brain as well, where we might be able to help with some focal or local SRS-based treatments. Obviously, tarlatamab has good penetration in the brain, and we'd hope that we'd be able to get some benefit there for our patients. But certainly, in a general sense, it would be in that oligoprogression or oligometastatic setting. The one thing I would also say is, especially when it comes to intracranial disease, small cell lung cancer has a high propensity towards leptomeningeal disease. And we just have to consider what is the treatment with radiotherapy that we can offer. If it's a toxic or more toxic treatment like whole brain radiation, again, we need to consider what other options and alternatives are available. Whereas if you've got a treatment like SRS, which is generally a single treatment, well tolerated, patients often have low to no side effects. Of course, there are other late things to consider, but generally speaking, tolerated. And they're the sort of treatments that I'd love to be able to splice in with some of these newer agents, assuming that there's a side of progression. So, look, a lot of unknowns. I certainly don't have any good answers. We have to tread with caution. We have to look at toxicity profile and burden and how we can minimize those. And some of these prospective trials that start reading out where radiotherapy is incorporated will be really insightful in understanding how we can do this safely for our patients.
Yeah, thanks so much, DJ. I think that's such a considered response and really paradigm shifting in terms of, particularly when you speak about using local therapies in extensive stage small cell. That's exciting. And I hope that we will begin to see survival extending for our patients and more durable responses. And certainly that, again, is a call that to evaluate some of these things prospectively as well and use our research groups to answer important questions. I might just move on to, we've spoken a lot about tarlatamab, and it's really just the tip of the iceberg. And there's several new novel agents in the small cell space. I suppose a bit of horizon scanning, Surein. Can you talk us through maybe some top line? What are you looking forward to reading out, and what have you seen up and coming in various conferences and meetings?
Two of the most exciting trials I saw recently back were actually phase 1 trials. So at World Lung, we saw a subset readout from Delphi 303, and then at ESMO, we saw another subset readout from Delphi 303. So there were, I think, up to about 50 or 60 patients who were treated with the standard chemoimmunotherapy combination. In the switch maintenance, it was actually the immunotherapy. When I say immunotherapy, I'm talking about the atezolizumab, the valuemab, with tarlatamab, right? And the first line cohort, it was the use of tarlatamab up front with platinum etoposide chemotherapy and the immune checkpoint inhibitor. And what I was really fascinated to see is that in both those cohorts, the 12-month overall survival was 80%. Now, I know these are small numbers. I know this is a phase 1 trial, but I don't think we have, in fact, I know we have never seen 12-month overall survival like that in the first-line setting of small cell lung cancer. That's really revolutionary. So what I'm really looking forward to is the readout from Delphi 305. This is the phase 3 trial looking at switch maintenance of tarlatamab and durvalumab. I suspect will read out, if not late next year, then possibly the year after. And then, of course, Delphi 312, which is currently recruiting in several sites in Australia, which is the first-line trial. I'm looking at the standard of care versus the standard of care plus tarlatamab. So this is what I think is going to be very exciting. But of course, while we are seeing this, we're also seeing the antibody drug conjugate space evolve. There are multiple different ADCs that are active in small cell lung cancer. We have B7H3 ADCs such as IDXD. We have SEZ6 ADCs such as the AbbVie compound, and we have DLL3 ADCs as well. And these drugs are starting to make its way into various forms of phase 3 trials. So it is in some ways very difficult to anticipate what the landscape is going to look like. In my mind, I would like to think that the first line landscape may be an antibody drug conjugate with a T cell engager and possibly with an immune checkpoint inhibitor as well. I think that'll be very revolutionary way of treating these patients. And of course, it's going to come down to toxicity, and we can't forget it's going to come down to cost as well.
Definitely. And I think what would also be revolutionary is if we could institute precision medicine within our clinics for small cell, where we have not been able to do before, where we do take a one size treats all approach. So I also wanted to ask you, Surein, any potential biomarkers that you might be aware of in small cell, or are we yet to uncover things?
So this is an interesting space, and there have been some subset analyses from the IMpower 133 trial where a transcriptomic signature has been established. And essentially what they've done there is that they've been able to work out 4 different transcriptomic signatures where they found that there was an inflamed subgroup that appeared to benefit more from the addition of the atezolizumab. Now, this is very much a research tool. We also know that there is relative heterogeneity within tumors, whereby some tumors may have more than one subtype, although one may be more dominant than the other. And in fact, what was really interesting is that this concept has been taken on into a large trial in the US. So the SWOG, which is the Southwest Oncology Group, similar to TOGA in Australia, if you like, they have taken this concept of looking at transcriptomic signatures and using a switch maintenance approach based on the transcriptomic signature. I think that's going to be really interesting. That's the first time I've ever seen some form of precision type trial in small cell lung cancer. And it may just be the tip of the iceberg to how we run trials going forwards. And I suspect that we are going to start seeing some data in the near future as well with the not just the ADCs, but the T cell engagers in terms of where these transcriptomic signatures may fit, and if there is a particular subtype that may benefit more from certain therapies.
Yeah, and I think that's a nice place to wrap up our wide ranging discussion on small cell today. I suppose I wanted to ask you, DJ, what are your kind of key take home messages for any clinicians who treat extensive stage small cell? What should we as a community would you like to communicate?
Yeah, so many learning points. And I must say that was a very interesting discussion to listen to. So thank you for including me in this. But I think at a high level, radiotherapy for small cell lung cancer, we know that it's a very radiosensitive illness. And so certainly from a local control point of view, we have a few advantages potentially for the patient in adding radiotherapy. If someone is symptomatic and we feel like their systemic treatment isn't quite holding that symptomatic area, then local radiotherapy, either with standard treatment or with a stereotactic treatment, I think is a very useful and versatile way of improving the patient's symptoms. And then, of course, the other areas that we've discussed in terms of with this improvement in systemic tumor control, and we know that small cell is and tends to be a very system-wide illness in that it's hematogenously very, very diffuse in many settings. And so I think the key here is always developing better systemic treatment options for our patients. And as we're heading into this era and improving outcomes, I think there's going to be more opportunities for local treatment to hopefully keep patients on these systemic drugs for a little bit longer. And that would be where I see us changing. And I guess just like you've both alluded to, having biomarkers or stratification pathways for which patients might do better on their relevant systemic agents would also guide radiation oncologists and maybe give us a little bit more confidence in when we should be adding a local treatment like stereotactic treatments. Very interesting. In the brain sort of setting in particular, I think there are some interesting changes in terms of avoidance strategies for radiotherapy, especially with more active drugs in the brain, and perhaps coupling treatments such as stereotactic radiation and stereotactic fractionated radiation treatment to reduce the burden of illness in the brain, which we know is important for symptomatic and for other quality of life endpoints such as driving and independence.
Absolutely. And Surein, was there anything you wanted to add in this new era of small cell treatments?
I think that it's suffice to say, small cell has become arguably one of the most exciting forms of cancer to treat. I think that we are using drugs that we have never used before and seeing some incredible activity. And in fact, more to DJ's point, and although we didn't really go into that, something really interesting with the use of these T-cell engagers is that we can see that the overall survival is clearly improved, but the progression-free survival may not be quite as impactful. And from my anecdotal experience, I believe that the drug alters the biology somewhat, that we are now moving patients not just into further lines of therapy, but also into the ability to have treatment in an oligometastatic fashion. So I actually think that radiation is going to play and continue to play a huge part in the treatment of patients with small cell lung cancer. And we're now starting to look at managing the disease, like how we manage EGFR when we first learned about TKIs. And I know that's a very bold thing to say, but I think that equally with the unbridled enthusiasm that I have displayed, it is also incredibly important to acknowledge that that some of these patients just present really unwell and may not necessarily get to these therapies. We are talking about an older group of patients with comorbidities. So some patients are going to still miss out on these sorts of treatments. But also, I think that with the treatments coming into play, especially with these T-cell engagers, we need to improve access to ensure that patients across the whole of Australia can get access and that the workforce is upskilled so that we can manage these unique toxicities. So hopefully this is just really a conversation starter for our listeners. And I ask of everyone to share the enthusiasm that all of us have had today with managing small cell lung cancer.
Thank you, Surein, and thank you, DJ. It's been such a great discussion with both of you this evening. And I really hope our listeners, whether you're a clinician or researcher, a consumer or advocate, you come away with a sense of hope for the future of small cell. I believe as well we're on the precipice of a real shift in our treatment paradigm, and we hope that these treatments are able to reach the people who need it the most. Once again, I'd like to thank our sponsor Roche for sponsoring today's podcast. I'd also like to mention our small cell lung cancer masterclass, which will be held by TOGA on the 20th of March 2026. This will be a face-to-face event in Melbourne, and it will be an advanced interactive workshop aimed at healthcare professionals. We have an excellent lineup of international and local speakers. There will be early bird tickets available, which ends the 16th of February 2026. For more information, head to the TOGA website. And as always, thank you for listening to TOGA's Conversations in Lung Cancer Research. If you enjoy our show, please rate and review us on Apple Podcasts and Spotify.